Hello everyone and welcome back. Today we are studying attention deficit hyperactivity disorder, also known as ADHD in short. My name is Michelle and I will attempt to cover everything you need to know about the topic at the level of a final year medical student. Here is a basic breakdown of the contents I'm going to be covering in today's presentation. So, ADHD is characterized by a combination of problems, including difficulty sustaining attention, hyperactivity, and impulsive behavior. It presents in multiple settings, resulting in social and educational difficulties. There is no single known causative factor for ADHD, so it is multifactorial. Many of the contributing factors fall under the categories of genetic origin or developmental origin. There is a greater concordance of ADHD in monozygotic twins, and there is an increased risk of ADHD development if the patient has a sibling or biological parents who have ADHD. Developmentally, if there is evidence of soft neurological deficits resulting in relative dysfunction of the prefrontal cortex, and if there is any history of brain insults, such as a premature birth, or toxins such as smoking and alcohol use in the first trimester. Other risk factors include severe abuse or neglect during infancy. In order to diagnose a patient with ADHD, they must meet the DSM-5 diagnostic criteria, which includes criterions A to E. So criterion A, persistent pattern of inattention and/or hyperactivity and impulsivity, at least 6 symptoms of each group for at least 6 months, that interferes with function or development and negatively impacts directly on the social, academic, and occupational activities. Symptoms that are indicated under the group of inattention include being easily distracted by unrelated stimuli or thoughts, difficulty organizing, no follow-through on instructions, careless mistakes, difficulty maintaining attention, listening problems, loses items needed for tasks or activities, and reluctant to engage in tasks requiring a sustained mental effort. Symptoms that are listed under the hyperactivity and impulsivity group include a very energetic patient who is always on the go, blurts out answers because they can't wait for their turn in class, unable to play quietly, interrupt a lot, talks excessively, fidgets in their seat, or runs and climbs about. B. Several of these symptoms must be present before 12 years of age. C. Several symptoms in at least 2 different settings. D. Symptoms interfere with the social, academic, and occupational function. And E. Lastly, symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and is not due to other general medical condition or substance use. Here is an acronym, attention minus the T. This is a memory prompt to remember the symptoms listed in the DSM-5. So there are 3 main specifiers for ADHD. Specifier number 1 is a combined presentation. This is when there is inattention and hyperactivity or impulsive criteria is met for the past 6 months or more. Specifier 2, this is a predominantly inattentive ADHD. So an inattentive criteria is met, but the hyperactive or impulsive criteria is not met in full for the past 6 months. And specifier 3, this is a predominantly hyperactive or impulsive ADHD. This is where the hyperactive or impulsive criteria is met, but the inattention criteria is not fully met for the past 6 months or more. There are quite a few comorbidities that exist with patients dealing with ADHD. These include oppositional defiant disorder, conduct disorder, substance use disorder, anxiety disorder, MDD, enuresis, bipolar disorder, learning disorder, epilepsy, and temperament and visual motor perceptual impairments. The course and prognosis of ADHD is quite variable, so it depends on the individual and their environment. The symptoms of ADHD can continue into adulthood, or symptoms can fully remit. Or sometimes hyperactivity can disappear, but the persistent attention problems continue on. So persistence of the symptoms really depends on the family history. If there's a strong family history of severe ADHD, that is a poor prognostic factor. if there are negative life events, and if there is harsh parenting or comorbidities. These all contribute to a poor prognosis. Now, the management of ADHD is biopsychosocial, so it's a multidisciplinary team management. Not all children require medication, and this is based on individual assessment on the severity, impact, and developmental appropriateness of the symptoms. The management under biological is generally separated into those of stimulants, methylphenidate, and non-stimulants. A little bit more information on the stimulants. The methylphenidate, it is the first line of treatment. We usually start off with a 0.5 to 1 milligram per kilogram in children 6 years or older, and you increase this weekly until improvements are seen. There are 3 main formulations of methylphenidate: Ritalin IR, which is instant release, Ritalin LA, which is long acting, and Concerta, which has the longest half-life of the 3. Before we start with methylphenidate, we would do a pre-treatment procedure, which includes your physical examination, excluding arrhythmias or cardiac conditions, as methylphenidate can exacerbate those. And in some individuals, depending on the history and risk assessment, we would want to do an EEG or CT brain. And lastly, do a baseline blood to check for liver function and kidney function, and also once started on the medication, we would like to see the baseline blood again to see if there is any change in those liver functions and kidney functions in case there is some sort of toxicity. Side effects include decreased appetite and weight loss, stunted growth, insomnia, nausea, vomiting or abdominal cramps, dizziness, tics or rebound hyperactivity, palpitations or increased blood pressure. So, as mentioned before, the stimulants are the Ritalin and Concerta mainly. Then the non-stimulants include Strattera, venlafaxine, and bupropion. The next step of the management is the psychosocial. So we would like to do psychoeducation for both the patient and the family, and then psychotherapy. In psychotherapy, older children with ADHDs are encouraged to talk about their issues that bother them. You should explore the negative behavioral patterns and find ways to deal with the symptoms together. Also, cognitive behavioral therapy is also the mainstay of the psychotherapy in ADHD. For social therapy, we do parenting skills training, so how to parent a child with ADHD, social skills training for the child, family therapy, and schooling support if needed. Okay, that brings us to the end of today's presentation. I hope it helps. Please leave any of your thoughts on how I can improve in the comments below, and good luck for all your examinations.